Okay, students, so the last PowerPoint that we're going to be doing for week 2, chapter 12, antifungal and antiparasitic drugs. So I always like to start this chapter by talking about some herbal and holistic alternatives to antifungals and antiparasitics. We also know there's lots of herbs and holistic options for antibacterial purposes. But good antifungal herbs include oregano, which treats candida, including Candida albicans, and also black mold, Aspergillus niger, and thyme, which treats Candida albicans as well, and some other fungal infections. Cinnamon oil, cumin, rosemary, garlic, ginger, basil, fennel, coriander, all different types of fungal infections. So basically your spice cabinet, right? Just I thought that was interesting. And I like to share that before we even get started. So much like bactericidal drugs, antifungal drugs are also either fungicidal, meaning that they kill the bacteria because they're highly concentrated, or fungistatic, which means that they stop the replication of the fungus or the spread of the fungus. Some antifungals are used prophylactically, which means in advance, just in case, to prevent fungal infection in patients that are immunocompromised. Some antifungals are used to treat superficial or deep fungal infections, systemic infections, superficial infections of the nail beds and oral, anal, and vaginal areas. So when we talk about superficial fungal infection versus deep, superficial would be those first layers of tissues, things like the mouth. Thrush is a superficial fungal infection, or yeast infection under the breasts or in the groin folds would be a superficial fungal infection. Even vaginal and anal yeast is a superficial fungal infection, even though it's technically inside a portion of the body. Those deep fungal infections we're talking about is more like candidemia. So where we get that fungus actually floating through our bloodstream and causing systemic infection. And then we have the lovely helminthic and protozoal infections and amoebiasis. These are parasites. So helminthic infections are invasion of the body by a parasitic worm. So round worms, tapeworms, right? Pinworms, oh, all the worms. Ironically, or I guess counterintuitively, ringworm is not a worm. Ringworm is a fungus. It's not even a parasite at all. It's a fungus. So that one isn't a worm, but all of the others are worms. And we give antithelmic drugs or anthelmic drugs in order to kill those worms or those parasites. We also see protozoal infections, which are caused by single cell parasites. And we have some anti-protozoal drugs that work really well to inhibit DNA synthesis. That means that they do a really great job of killing the organism. And then we have that amoebiasis, which is a parasitic GI disorder, when we see those parasites get into the GI system. Topical administration of antifungals. So this would be like your medication for the yeast infection that you would apply topically. Additionally, you have creams like ivermectin creams for parasites, right? So antifungal, think vaginal yeast cream. And then topical administration for antiparasitics, think like ivermectin or another type of cream paste that we can apply on the body. Now, ivermectin is also a PO, but there are different types of topical antifungals and antiparasitics. So when we put it on the skin, sometimes we might see skin reactions like irritation or burning, maybe some redness or stinging, and maybe some belly pain if we're putting the antifungal topical drug into the vagina. And then systemic administration, so if you're taking it by mouth, like a diflucan pill, you might see headache, rash, nausea, vomiting, diarrhea, anorexia, general like weakness or muscle aches called malaise, or abdominal joint or muscle pain. We don't want to give antifungal meds to anybody who's allergic to the drug or is pregnant or lactating. Contraindications for antifungal drugs include patients that are on griseofulvin or voriconazole or itraconazole. Used carefully in patients that have a history of kidney dysfunction or liver issues. And there are lots of interactions with drugs, so you want to make sure that it's compatible with the drugs that your patient's on. Before we give an antifungal, we want to make sure that we get the signs and symptoms of the infection assessed and recorded before we give that first dose. We also want to get a baseline set of vital signs. We really want to look at those superficial fungal infections of the skin or skin structure. So lift up the breast, look in the abdominal folds, look in the groin, right? And really see if it's like a popular rash or if it has any type of exudate, like what does the rash look like? Ask about the pain of the rash and look for white plaques, especially in the mouth, right? Those white patches are really indicative of thrush. And then in the oral or perineal areas, we might see vaginal discharge, usually thick, white, creamy, sometimes yellow, and itching will accompany that. Ongoing assessment. If this is an inpatient, we want to observe the patient every 2 to 4 hours for adverse drug reactions. Additionally, if we're administering topically, we want to educate the patient about looking for, first of all, is it improving? And second of all, are you experiencing some type of reaction to the drug? Is there redness or increased raising of the rash? Is there an issue, right? Okay. Impaired comfort related to IV administration of amphotericin B, which is one of those drugs that we might be using. It is not exactly comfortable going in. So we'll talk about the nursing interventions that we can do to make this a little bit more bearable for our patient. And then risk for inefficient or ineffective tissue perfusion related to our kidneys, right? And an adverse reaction of that antifungal drug is hard on the kidneys. Okay, the expected outcome would depend on why we're giving the drug, right? But regardless, we want to see the response to therapy. The patient will be able to understand that there are adverse reactions, understand why they're taking the medicine, know what to report to the doctor, and be compliant with their drug regimen. So with amphotericin B, promoting an optimal response to therapy. You want to protect that IV solution from exposure to light. It is light sensitive. So that medication is light sensitive. That means that light can actually disrupt its ability to work properly. So that's kind of a big deal. We want to make sure we keep it protected. There's usually little brown bags that go around it. We want to administer immediately after it's reconstituted. It cannot be used after 30 minutes. You need to use it as soon as it's reconstituted. Renal damage is the most serious adverse reaction to the use of amphotericin B. So you need to be checking those kidney labs. Remember kidney labs, we talked about this with nephrotoxicity and some of our other medications. We talked about needing to check creatinine, serum creatinine, and BUN or blood urea nitrogen. Those are two metabolic wastes that circulate in our blood after being picked up from the tissues and our kidneys get rid of. So if our kidneys aren't doing a good job, it's not going to be getting rid of those wastes. And when we draw the blood, we will see elevated levels in the blood. With topical antifungal infection preparations, we want to inspect the area at the time of each topical application to make sure that we don't have any tissue issues. We want to, if we're administering vaginally, ask the patient if it's uncomfortable, any other type of sensations like itching that they're experiencing, and evaluate and chart how their responses are changing on a daily basis. And then impaired comfort for medication administration. We talked about how this can be uncomfortable, right? So tell them obviously that it's an uncomfortable medicine to go through the IV, maybe get them some blankies, make them sure that they know that we have to give it. And we're going to give them some pre-medications in order to help the reaction of that antifungal. Risk for ineffective tissue perfusion. So this is for our kidneys, right? So we need to be watching to see if we're putting out enough output. So that's greater than 30 milliliters per hour. If we're drinking enough, and if we're drinking, are we getting all of that out and output except for, what our body uses? Serum creatinine levels and BUN levels. So those blood levels of those kidney labs. And then with fluconazole, we see that our elderly really, really have a hard time with that medication. It is especially hard due to their decreased GFR, glomerular filtration rate. As far as education, we want to educate our patients to make sure that they clean the area before they apply the ointment, use the appropriate amount, and do it at the prescribed frequency. For ringworm, which we talked about how that is a fungal infection, not a helminthic infection, we want patients to use different towels and face cloths for bathing because it is contagious. Okay. Teach drug-specific points for the following drugs. So flucytazine, griseofulvin, ketoconazole, itraconazole, miconazole. You may have, each one of those is going to have particular indications. For example, ketoconazole, we really want those patients to monitor for irritation because it has an increased risk of irritation more so than the others. Just really knowing your drug well, getting maybe a drug handout for your patient and providing your patient with that education in advance of taking that medication. The therapeutic effect is achieved. Yay! That's what we want to see in our evaluation phase, right? Signs and symptoms of infection have improved. Optimal skin integrity is maintained. We've identified, reported, and managed and mitigated all of those adverse reactions. And the patient and family understand and comply with the therapeutic regimen. Antiparasitic drugs. Why do we use antithelmics? We talked about this a little bit. We use them to keep parasitic worms from invading and multiplying inside of our body, called helminthiasis. Yuck, right? And then we give antiprotozoal drugs to protect against invasion of single-celled parasites. Adverse reactions to antithelmic drugs may include, drowsiness, dizziness, nausea, vomiting, abdominal pain, maybe some cramping or diarrhea. If we develop a rash, we really want to let the doctor know. Antithelmic drugs, antithelmintic drugs are contraindicated in patients who are allergic to the drug or are pregnant. We obviously don't want to ever compare humans to animals, but you know that you can't worm your dog when it's pregnant. Same thing goes for your human patients if they're pregnant. We don't want that to be done because it can go to baby. We also want to use these cautiously in patients that have liver or kidney issues, are lactating, or are already malnourished or anemic. Okay, dexamethasone and antithelmintic drugs can cause interaction. For example, albendazole is a particular antithelmintic drug that we use. And if you give albendazole with dexamethasone, it increases the amount of albendazole in the body and actually can basically increase the dosage because it's working more effectively in the body. Tagamet or cimetidine is the same situation, except that it interferes at the elimination part of the pharmacokinetic process, meaning that the albendazole doesn't ever leave the body. So you have an increased dosage of that due to decreased elimination. And then heightened towins, so all of our seizure meds and carbamazepine, lower the levels of certain antithelmintic drugs like mebendazole. Okay, antiprotozoal drugs, how do they work? Well, they interfere with the life cycle of the plasmodium. So that keeps them from developing and prevents your mosquito from ingesting the plasmodium. They're used for malaria, giardiasis, toxoplasmosis, intestinal amoebiasis, and sexually transmitted infections, as well as pneumocystis pneumonia. GI reactions to antiprotozoa drugs can include vomiting, anorexia, abdominal pain, diarrhea, and nausea, the good old traditional GI issues. Other body system reactions may include headache, dizziness, trouble with the vision, low blood pressure, light sensitivity as far as the skin's concerned, synchronism, peripheral neuropathy, nephrotoxicity, and ototoxicity, especially with paramomycin. Which is a particular antiprotozoal drug. These are contraindicated if the patient is allergic or they're pregnant, and we want to be very careful when giving these to children or lactating patients, and also with patients that have liver, kidney, or bone marrow issues. Quinine is not great for patients that have myasthenia gravis. It is known to exacerbate their condition. So interactions for our antiprotozoal drugs. So when we give an anti-malarial medication, sometimes with a calcium-containing or iron-containing substance, we have that decreased absorption that we've seen with several different of our antibiotics. Digoxin, given with an antiprotozoal, can actually increase the risk of digitoxicity, so we don't want to do that. Barbiturates, phenytoin, carbamazepine, all of our seizure medications actually decrease the effects and effectiveness of doxycycline. And then warfarin increased our risk of bleeding with that one. Okay, so going into the nursing process, if we talk about diagnosis for antiparasitic drugs, these patients might experience diarrhea related to parasites, deficient fluid volume related to the parasites being in their body and not being able to take in as much water, or having their water depleted, right? Their nutrients depleted. Same thing with imbalanced nutrition, less than body requirements. Not only are they going to be nauseous and probably anorexic as far as lack of appetite, they also may not be able to get the nutrition that they need from the food that they do ingest. And then risk for impaired respiratory infection or function if we are having a negative response to the drug therapy. Planning is really going to depend on your patient, what kind of infection that they have, what kind of parasite is affecting them. But we definitely want to reduce their anxiety, make sure that they're responding to the drug appropriately, we're managing and identifying any adverse reactions, and that our patient understands and complies with the drugs. Okay, how do we promote optimal response to therapy? Well, we provide great education. We explain the treatment and how we're going to prevent this from coming back in the future. We discuss any concerns that the patient and their family have. We answer any appropriate questions. And then if there is a hospital policy on linens, like making sure that we toss them or that they go into bio, et cetera, let's make sure that we're following that. So you're going to want to look at your policy for linens when there is parasite infection. Okay, monitor and manage your patient's needs for diarrhea and the risk of fluid body deficit. Oh man, fluid body volume deficit. You want to be doing obviously I's and O's on the patient. They might need some IV fluids or electrolyte replacement. Risk for imbalanced nutrition because of that GI upset that's causing the nausea, vomiting, abdominal pain, diarrhea. Maybe change what they're eating, encourage an intake of a nutritious meal, and make sure that we're giving them foods that they prefer. That way they're more likely to eat them. Also, oral care before and after meals will be helpful for that one. And then risk for impaired respiratory infection with an inhaled treatment like a pentamidine, pentamidine. I'm gonna get it, guys. Pentamidine. Okay. Bronchodilators may be prescribed to open up those airways, and you wanted to teach the family and the patient how to use those. Also, as far as educating our patient and family, instruct them about taking the drugs as well as the household precautions to be followed until that worm is eliminated, right? What do we need to do around the house so that we're not spreading this amongst the family members? And then make sure that they've got a really great education plan to follow at home and that they understand the education provided via teach back or return demonstration. Evaluation, we've given the antiparasitic and we've achieved the therapeutic effect. No more worms, or at least it's managed, right? Our adverse reactions were identified, reported, and managed. Our stool specimen came back negative for all those bugs. Patient verbalizes an understanding of the therapeutic regimen modalities, and they know that it's important to continue testing after they leave to make sure that we've effectively eliminated whatever parasite they had hanging out, right? And then compliance and for future prevention is going to be big here. Okay, so let's test your knowledge. Itraconazole is taken on an empty stomach. Therapy continues for at least 6 months until the infection is controlled. So you guys will notice we didn't talk about the specific drugs as much as we usually do. That's because just like with our antivirals and antiretrovirals, most of the drugs have the same ending. So for our antivirals and antiretrovirals, they all end in like vir or clovir. For our antifungals, most of them end in conazole or zole, right? So that's how you're going to differentiate them from other drug names. But there are a ton of them. That's the other reason, and lots of the same issues. So if it's mentioned in the PowerPoint, I would know it. So for example, these itraconazole administration instructions, but I wouldn't stress out over memorizing every antifungal provided in your textbook. Okay, so let's find out if this is true or false. It is false. We actually give itraconazole with food because it causes GI upset, and we want therapy to continue with this particular medication 3 months until the infection is controlled. Okay, fungus. Is fungus a single-celled plant that can cause yeast-like infections? True or false? It's true. It is a single-cell plant that can cause yeast-like infections. These are called fungal or mycotic infections, and antifungal drugs slow or destroy that fungi. They're either fungistatic or fungicidal. Is this following statement true or false? Superficial fungal infections to the skin, nails, and genital area are bothersome, and they're treated with parenteral medications. Gotta think back to unit 1 and all the stuff we learned in week 1 about parenteral enteral. This one's false, right? Not parenteral. These medications are usually topical, right? Or oral, enteral. Superficial fungal infections to the skin, nails, and genital area are bothersome, but are treated topically or by oral preparations. Systemic infections, so when we're talking about serious infections, especially those when the fungus is in the blood, are treated with parenteral or IV medication. Okay, so just quick review of what we talked about. We talked about antifungal and antiparasitic meds. How do you focus this content? Like I said, I don't want you stressing out so much about the names of all the different antifungals, but I do want you to know some of the particular diseases or indications for antifungals, like ringworm, so cradle cap, right? Thrush, vaginal yeast infection, right? And then I want to talk to you about vaginal cream, right? So we talk about a lot about vaginal cream as an option for treatment. We did talk about that today and how there's itching and that discharge. When we're giving a patient a vaginal cream, we need to be sure that the patient applies it with the little tool that comes with the machine, with the med from the pharmacy, that they're wearing that panty liner after they put it in, so that way they don't stain their clothes and their bed linens, right? That they continue to take it even if they're on their period. Okay, and if there's no improvement after about a week, they need to let their doctor know, and then and we'll go from there. And we don't want them to have intercourse while they're on this drug, because they can actually spread the drug, or excuse me, spread the fungus back and forth between themselves and their partner. So we definitely don't want them to become reinfected. So no intercourse, no sexual content. And then we don't want them to wear anything that's really tight fitting, that's going to allow moisture to build and potentially contribute to reinfection. So I know that the screen is black and I'm just talking to you, but that's some really important information about particularly miconazole vaginal cream, right? Okay. Okay, I think that that's all that I have for you guys as far as antifungals and antiparasitics are concerned. You guys know that ivermectin is a highly controversial antiparasitic right now because they're using it as an antiviral off-label for COVID. So just something maybe to do some research on and kind of learn more about. I think that might be interesting to dig into. But I thank you for your time, and I hope that these voiceover PowerPoints were helpful to you in prioritizing your learning. Take care.